Our third speaker is Mike Wiltermood, who's the CEO of Enloe Hospital. And when I approached Mike about having Enloe sponsor this activity, I get just a glimpse of what his job must be like, because he was actually initially very enthusiastic, but you could kind of see the wheels turning as he tried to figure out how much it was going to cost. And when he figured out it wouldn't cost too much, I think I got an idea of what his job is like, trying to balance Enloe's mission in the community in very difficult economic times. I think it's a job that he does with both intelligence and compassion, and I think he's well placed to talk about the hospital's perspective on health reform. Mike Wiltermood.
Well, in spite of the cost, we're very happy to host this forum. Although, if anyone wants to donate to a new microphone, please meet me after. You know, it's interesting to approach the issue of healthcare reform going back to the beginning and recognizing the reasons why healthcare reform started in the first place. And as most of you know, there are two basic reasons why there's such a push for reform in general. One is that healthcare is very expensive, as we've heard, and the other is that it underperforms relative to the cost. Now, I'd like to defend the industry just a little bit and talk about why there is a reason for the state of affairs in healthcare as it currently exists that is really out of the control of the practitioners of healthcare, physicians, hospitals, et cetera. Now, keep in mind, healthcare is very complex. Obviously, different people have different ways of approaching the statistics. As you know, Mark Twain once said, lies, damn lies, and statistics. I will try to keep this brief, but just to give you some things to think about. In the 1960s, when Medicare and Medicaid legislation was passed, the average life expectancy for an adult American was about 64 years of age. Does anybody know what the average life expectancy is now? 77. Now, Medicare and Medicaid programs at least made a dent into universal access. As Dr. Abrams pointed out, we still have very much a two-tiered system. But healthcare, that money that was put into healthcare over the years did a job, and that was to increase the life expectancy of Americans. And we are paying for that right now. Actuarially, in the 1960s, we died before we had a chance to receive social welfare, Social Security, Medicare, et cetera. Now we're living 10, 15, 20 years beyond that. In the 1960s, there were 4 taxpayers for every recipient of a social benefit program. By the year 2025, taxpayers will be paying for not only themselves, but for another beneficiary. There'll be a 1-to-1 ratio in terms of how we pay for those social benefit programs. So that's the real economic pressure, and it's largely driven by demographics. Now, clearly, when we go from 3% of the gross national product as an industry in the 1960s to 18% in 2010, something is wrong, even if we do have that demographic pressure, and we need to do something about that. I think it's interesting, the sequences of events that have taken place as the government became involved in healthcare in a big way through the Medicare and Medicaid programs in the 60s. In the 1960s, physicians were the most respected and trusted profession in the country. Hospitals were among the most trusted and respected institutions in the country. They were right up there with churches and universities. By 1982, physicians had been replaced by actuaries, and hospitals had been replaced by banks. Now, I don't know if that's changed since then. But you see the shift to people who control money, who evaluate money, and it's been an interesting shift over the years. Now, I agree with the speakers that have preceded me in all respects. Healthcare reform does not address the fundamental issue of cost. It rearranges the deck chairs on the Titanic. It simply reshuffles how money is paid. And unfortunately, that's going to cause some problems for us locally, and I'll try to illustrate that here with our personal example at Enloe Medical Center. One of the fundamental problems with the way our system works, besides the fact that we have a two-tiered system, is the inequity in how payments are made to varying providers. On a broad basis, it may surprise you to know that physicians in Butte County do not receive the same amount per incident of care from commercial insurances that their peers in other areas do. The Wall Street Journal had a very interesting article a couple of months ago that illustrated this point relative to healthcare reform. And in that, the author made the argument that while healthcare reform is supposed to increase access and reduce costs, it would do neither. Because as healthcare reform reduced payments to providers, providers would consolidate. Large corporations with big bankrolls would be able to pick up independent practicing physicians, independent practicing hospitals, and create conglomerates which would then drive the price of healthcare. And we're already seeing that. Many physician specialties across the country are merging with hospitals. Large physician groups are picking up physicians in specialties in their area, and they're starting to drive the price. I'll give you an illustration of this. Now, again, lies, damn lies, and statistics. Some of this is anecdotal, but it's illustrative. The average family physician in Chico probably gets about 90% of Medicare payments for family practice visits. Now, that may surprise some of you to know that our physicians sometimes take less from a commercial insurance plan than they do from Medicare, because with hospitals, that's not the case. In large group practices, where physicians have large market share and can drive prices, they can command amounts in excess of 140% of Medicare. Now, when you think about what we need as a community, that's very disconcerting. And one of the biggest threats of healthcare reform is that as payments become squeezed, people will be discouraged. The best and the brightest will be discouraged from entering into healthcare. Now, the squeeze may provide some relief to budgets, some budgetary relief for a period of time, but usually it catches up with us. And a couple of illustrations for you. I believe it was back in 1986 when the Medicare program started to reduce payments to teaching hospitals to subsidize physician and nurse rotations. In other words, we had a big program, some of the physicians might remember this. Teaching hospitals wanted to have residency programs, and they wanted to have nursing education programs. And as that payment has been taken out of the Medicare system, we've seen shortages in numerous specialties in physician care as well as nursing. Now, that is going to repeat itself in a big way. We already have shortages in areas like lab technology, radiology, nursing, and a myriad of physician specialties. Depending on which specialty you want to talk about, you'll get different numbers and different answers. Clearly, there is a dearth of primary care physicians in our community and nationwide, and Dr. Abrams made the point that if you are a Medicaid recipient, it's very, very difficult to find care because physicians are, in order to cover their overhead, and in order to make a decent living, and I'm not saying an exceptional living, I'm saying a decent living relative to the money that they owed coming out of school and the time they spent to get through school, they are forced to be selective in terms of how many Medicaid patients they will take versus Medicare or commercial insurances. Now, hospitals in our position, sole provider hospitals that have a relatively uncontested market share, have been successful in commanding larger payments out of commercial insurance plans. In our area, we have to be very concerned about the pressure that places on especially small businesses. Interestingly enough, we see that ourselves because we have to insure our own employees. So if we're expensive, our premiums are expensive. So we see that direct correlation. But healthcare reform does not address the fundamental cost associated with with providing health care. It does nothing to bring more physicians to the market, more nurses to the market. It does nothing to ease the cost of bringing drugs and equipment to the market. Our budget at Enloe Medical Center is about 50% dependent on our employees. Now, if our employees are in short supply and we have to increase our cost 20% or 10 or 15 or 20% in given areas in order to attract people to our community, then that results in many millions of dollars of increase in terms of how much it costs us to cover our budget. Another 30% of our budget goes to supplies, and as Dr. Lebowski discussed, we are already seeing the effects of consolidation in the pharmaceutical market. Might interest you to know that there's only one company that makes snakebite antidote right now. And that's just one example. We are facing the next year or so in particular, we know that we're going to be faced with severe shortages in pharmaceutical supplies because over the years, hospitals have been very good about consolidating their purchasing agreements and putting pressure on vendors such as pharmaceutical companies to lower their prices. Well, what have the pharmaceutical companies done in response? They've consolidated as well. And now they're the driving force in terms of cost. In some cases, they can absolutely dictate terms, and it's causing problems for us already. Our position as a hospital, as a freestanding, mission-driven, nonprofit hospital, fundamentally is, if we have enough money to take care of people, we're okay. So, in a way, how the money gets distributed doesn't really matter that much. Some folks have asked me, is healthcare reform going to provide a benefit to hospitals such as Enloe Medical Center? Because it's healthcare reform promises to insure folks that do not currently have insurance. And my answer is it makes no difference to us. The reason why has been illustrated by the previous speakers to some degree, but let me just give you an example. It does not matter to us if one person pays $1 and another person pays 0, or two people pay 50 cents. It's the same amount of money. And as the pot is not going to get any bigger for us. We understand that we have to do our part for healthcare reform. One of our major concerns, though, in this debate is that as the budgets get squeezed, that our local institutions do not get pulled into a situation where we're pointing fingers at each other. And one of the main concerns that we have is that the people that we serve understand that the pressures that come to our physicians, that come to our hospital, that come to other healthcare providers in our area are external in nature. You've seen how on the news the budget crisis in states like Wisconsin and Ohio can actually lead to violence. Here, we have to understand that we do have to work together in a very real and local way in order to solve these problems. Now, the suggestions that have been made for healthcare reform are, I think, very well thought out. Our politicians, our communities have to have the will to implement those things because healthcare is extremely complex. And it's going to take a complex, comprehensive solution. But what we don't want to do is lose sight of the fact that our physicians, our local hospital provides a very valuable service to our community, and that without your support, without our collaboration in working out budget crises with our school systems, with our city governments, with our healthcare institutions, we're going to fail as a community. So we need that support. Our current situation at Enloe Medical Center is that we are now seeing the effects of budget cuts to the state and the downturn in the economy. We have typically averaged about $10 million in charity care. Now that's the gross charge for charity care that we write off on an annual basis. Suddenly that's gone up by almost 60%. At the current rate, we'll be providing $18 million to $20 million in charity care annually. We're also seeing an increase in bad debt. Now, we're able to manage this so far. And as long as we have good relationships built with our physicians, with our employees, and with our community, I think we're going to be able to weather the storm. But the next 4 years are going to be tough. If you can do anything at all to influence your congressman or your U.S. senators with respect to health care reform, the message that you're hearing from these physicians is the one we have to carry to them. We need to have relief in terms of cost. We need to have equity in terms of payment. Now, I don't know if we're going to make it. It's going to be interesting to see how healthcare reform gets sliced and diced over the next 4 years, because you know that no matter what bill has been passed, as Dr. Lebowski pointed out, special interest groups are going to be chipping away at this bill from now until forever. It's what we have seen since Medicare and Medicaid legislation came to pass in the 1960s. Let me just give you a little bit of an illustration of how this works and the lack of trust within the organization between the healthcare industry and the government and what that leads to. When Medicare and Medicaid legislation first passed, basically hospitals and doctors were able to just send Medicare and Medicaid a bill. And if we couldn't balance our budget, we raised our rates. Well, it didn't take long for the government to realize that we can raise our rates a lot. And so they started to intervene, and they started different programs, and the bureaucracy grew and grew and grew in an effort to forestall those payment increases. About every 10 years, the government has come up with some major plan. Now, what we have just for the process of billing and collections, we have thousands and thousands of codes, clinical codes, business codes, charges. You've seen your healthcare bill. Does it make any sense to you? I work in a hospital, and it doesn't make any sense to me. When one of my family members goes to the hospital and we have a hospital charge and a radiologist charge and a physician charge, I just wait until all the bills come in and see what my insurance paid for. Now, I'm a little more proactive about that now because I have to be because of my profession. I would like healthcare billing to be as simple as your credit card bill, and it should be. There's no reason why it has to be that complicated. It's a travesty that we spend millions and millions of dollars in this game of billing and collection. But all kinds of cottage industries have sprung up over this, and these are the hands in the rice bowl that Dr. Lebowski was talking about, these special interests. Medicare changes its coding procedure. People who work for Medicare start their own businesses to help hospitals and doctors understand how those codes work. Medicare decides that it's going to start looking at clinical documentation to demonstrate the validity of a given service. And again, a cottage industry springs up, born out of those former employees, to help hospitals and doctors refute insurance claims that a certain procedure was not required. It's almost like an arms race, except it goes in a very different direction. And we have layer upon layer of cost that develops for this very simple, should be simple process of just collecting our bills. I asked our physician groups one day how much money they could save if physicians' offices operated like a supermarket and you paid as you took out the service. Well, in this case, you'd probably not take it out exactly, but think about what a supermarket would have to go through if the scenario for them was this. A person who wants to buy food comes into the supermarket, accompanied by an individual dietitian who will advise them to what food that they should get. And as they go around, they can pick whatever they want. Depending on who your dietitian is, depending on what your food plan is, and you walk out of there with an armload of food without paying a dime. Now, how hard is it going to be to collect that? We say, hospitals say that we have our bad debt percentage is about 3%. But in fact, only about 10% of our total dollars billed comes from private payments. 3% out of 10%. That means we have 30% bad debt on out-of-pocket expenses. Supermarkets, under that same scenario, would have the same problem. And it would be very, very difficult. And so you can see how then politically, supermarkets would then start to lobby their politicians to say, this is an untenable situation, you have to give us relief. Well, okay then, we'll pay more money for hamburger. Maybe we'll pay a little less for steak. We'll give more access to rice. Maybe we'll provide some dietary counseling to help people make better decisions when they buy their food. See, these are all the layers that happen to healthcare. And unless we can eliminate those costs, reduce those costs in a rational way, we are not going to be able to deal with the cuts that come through healthcare reform. We are required to provide a certain range of services, and taking less money for doing the same thing is not a fix. That's the problem. So I'm not really sure, that's kind of a downer message. I was thinking ahead of time how I could kind of get out of this gracefully on a positive note. But what I would like to say, and what I think is relevant to the folks in this room, is that you can be very proud of the health care that you get in this community. We have a lot of physicians that are willing to sacrifice personal income in order to take care of folks. And that's very important. I think you have a hospital that takes its mission seriously. You have a board of directors for that hospital that actually cares that people get good health care in our community. And you can go to a website. If you want to know how efficient we are, there is a website that Medicare has that shows the average cost per Medicare recipient by region. Now, keep in mind, California is an expensive state. Our physicians pay probably 50% more in many cases to run a private practice than, say, Idaho or Montana. And yet, in our county, in Butte County, the average cost of taking care of a Medicare recipient is $7,800 annually compared to the national average of $8,400. So, in spite of what you see on your bill, and keep in mind, whatever you see on the bill is not what we get. Just as an aside, I mention to our employees sometimes if they want to sound like they belong to a big organization, they can say that they belong to a $1.4 billion corporation. That's how much we bill in a year. How much do you think we collect out of that? 22%. Now, I'm not complaining, even though the microphone may be not as good as it could be. We've had very fortunate support from our community, and we do what we need to do to take care of our community. But it's important to recognize that as we work through these challenges, that most of the things that we're dealing with are external. And we're going to need your support over the next few years in order to figure out how we respond to the changes that inevitably will come our way, to the budget cuts, to the increased federal and state mandates, increased regulations. I want to thank you on behalf of Enloe Medical Center for coming and also for your support.
Thanks, Mike. That was actually really interesting. A bit of a downer, but I don't know. Actually, I started getting hungry toward the end, so I'm heading off to the grocery store.